Good afternoon. My name is Natasha Thomas, and I will be giving a brief overview of body dysmorphic disorder, or BDD. BDD is categorized as an anxiety disorder, meaning that individuals who suffer from this mental illness are constantly overwhelmed with fear and worry to a point where it is impairing their normal functioning. Originally named dysmorphophobia, meaning fear of ugliness, BDD is when relatively normal-looking people think that they are so ugly that they refuse to interact with others out of fear that people will laugh at their ugliness. Patients with BDD complain of persistent, intrusive, and horrible thoughts about their appearance, and they engage in compulsive behaviors such as repeatedly looking in mirrors and checking on their physical appearance. This makes it easy to see why BDD has a 10% comorbidity with obsessive compulsive disorder, or OCD, where the obsession would be their thoughts about their appearance, and the compulsion would be constantly looking in the mirror and checking on their physical appearance. Researchers have also found that those with BDD and OCD have similar abnormal brain functioning, and that BDD and OCD have a similar age of onset and run the same course. Individuals suffering from BDD have an average number of 5 to 7 bodily areas of concern. As you can see from this chart, the top areas of concern found among those with BDD are skin, hair, and nose, respectively. About 25% of people with BDD use excessive tanning as a way to attempt to hide their perceived skin defects. Some also participate in excessive grooming, which may include skin picking, also known as excoriation. When it comes to mirrors, some individuals may constantly and excessively look in mirrors to check and see if any changes have occurred in their ugly feature, while others may completely avoid mirrors almost to a phobic extent. People suffering from BDD have ideas of reference, meaning they think that everything that goes on in the world somehow is related to them and their imagined defect. Some people may even become housebound out of fear of showing themselves to other people. The diagnostic criteria for body dysmorphic disorder include preoccupation with one or more defects or flaws in their physical appearance that are not observable or appear slight to others. At some point, they have performed repetitive behaviors in response to the appearance concerns, such as mirror checking, skin picking, excessive grooming, or comparing their appearance with that of others. The preoccupation causes significant distress or impairment in their functioning, and the preoccupation doesn't meet the diagnostic criteria for an eating disorder as shown by concern with body fat or weight. BDD has an onset in early adulthood through the middle 20s, with a peak around ages 16 and 17, and usually runs a chronic or lifelong course. BDD has a 1 to 2% lifetime prevalence, and about 4 to 28% of college students will meet all the criteria for BDD at a given time. BDD has a sex ratio of 2 to 1, with women reporting slightly more than men, though the disorder is seen as occurring equally between the sexes. Male BDD tends to focus more on body build, genitals, and thinning hair, while females are focused on more varied body areas. Men tend to have a more severe form of BDD, and women with BDD are more likely to also have an eating disorder. One theory suggests that BDD is caused by flawed neurobiological processes, specifically in the connection between certain areas of the brain to one another. The orbital frontal cortex, or OFC, sends an initial worry signal to the thalamus when it notices that something is wrong. When the thalamus receives this signal, it in turn sends signals back to the OFC to follow up about the worrying event. The caudate nucleus lies between the OFC and the thalamus and prevents the initial worry signal from being sent back to the thalamus after it has already been received. However, it is suggested that with OCD, which is similar to BDD, the caudate nucleus does not function properly and therefore does not prevent this initial signal from recurring. This causes the thalamus to become hyperactive and creates a virtually never-ending loop of worry signals being sent back and forth between the OFC and the thalamus. The OFC responds by increasing anxiety and engaging in compulsive behaviors in an attempt to relieve this apprehension. Another theory for the cause of BDD involves biological, psychological, and social factors. This theory suggests that BDD may be triggered in a person who is genetically predisposed to be anxious, which is a biological factor, who then experiences a triggering event such as being teased throughout high school about some distinguishing physical characteristic. The social factors come into play based on the fact that the individual is being teased based on unrealistic societal standards and expectations about being beautiful or handsome. And so the person is being bullied for not meeting such standards. As for the psychological factors, poor self-esteem and low parental support allows the individual to more readily believe that there is something terribly wrong with their appearance. As a result, the individual becomes anxious about their appearance, leading to body dysmorphic disorder. People suffering from BDD tend to be somewhat reluctant to seek treatment, so usually a family member will demand that the individual get some help. One method of treatment involves cognitive behavioral therapy, specifically exposure and response prevention therapy. The purpose of cognitive behavior therapy is to change the patient's thinking and behavior, with the goal of correcting the false belief about the defect and to minimize compulsive behavior. Exposure and response prevention therapy works by getting the individual to have their obsessive thoughts, in this case having a horrible bodily defect, without allowing them to act out the compulsion. For some people, this would mean not allowing them to look in the mirror, and for others, this would mean forcing them to look in the mirror. The hope is that by not allowing the person to act out their compulsion, it will reduce the individual's want to act out the compulsion, which would then allow the patient to function a little better, since they will be less preoccupied with acting out their compulsive behavior. Another form of treatment, though less effective, is prescribing antidepressant medications called serotonin reuptake inhibitors, or SSRIs. Serotonin is a neurotransmitter whose basic job is to control impulses and produce a feeling of peace, and it is believed that a lack of serotonin plays a huge role when it comes to developing certain disorders, including BDD. Some SSRI medications that are prescribed for BDD patients include anafranil, Luvox, and more commonly, tricyclics. A third form of treatment could be group and/or family therapy, because family support is very important to treatment success, and if family support isn't available, the patient would benefit from having support from a group with members also suffering from BDD and possibly OCD. Some BDD patients will prefer dermatology treatment or plastic surgery. In fact, 8 to 25% of people who request plastic surgery may have BDD. However, most BDD sufferers who seek and receive plastic surgery aren't satisfied with the results and continually go back for more surgeries, either on the same defect or on a new concern. The most common procedures include nose jobs, facelifts, breast augmentation, and jawline reconstruction. If a BDD patient wants plastic surgery but can't afford it or are denied the surgery, some will go to the extreme of taking matters into their own hands. For example, one man who was suffering from BDD thought his skin was too loose, so he used a staple gun on his face to keep the skin tight. It is important to know that depression and substance abuse are common among individuals with BDD. In fact, suicidal ideation, suicide attempts, and suicide are typical consequences of this disorder. Clinicians and psychologists should make it a priority to ask BDD patients if they are thinking about killing themselves before they leave each session. This concludes my lesson on body dysmorphic disorder. Thanks for listening.